Welcome back to the deep dive. Today we're diving deep into achalasia. This is one of the most intriguing disorders of the gastrointestinal system. And you've sent us a stack of sources, articles, clinical reviews, and some really cutting-edge research that I think lets us build a complete picture here.
It's a remarkable disorder because, as your sources really detail, the problem isn't a mechanical blockage you can just, go in and remove.
Right. It's not a tumor or scar tissue.
Exactly. The difficulty in swallowing here, it stems from a total functional failure. It's sort of a ghost in the machine.
That is a perfect way to put it.
Yeah.
When you hear about a patient who can't swallow food, your mind immediately jumps to an obstruction, a blockage.
Of course.
But in achalasia, the issue is so counterintuitive. It's a profound breakdown in the body's internal neurological coordination. It's a failure of the signal telling the muscle to open up.
That's the frame. And our mission today is to synthesize all this complex material you've gathered. We need to unpack that core mechanism, the targeted destruction of specific nerve cells. Understand the latest genetic and autoimmune theories, which are fascinating, and then walk through the diagnostic tools and the trade-offs of the treatments.
Okay, so let's start right there with the fundamental definition. When we talk about achalasia, what is the precise physiological defect we're looking at?
So achalasia is what's called a smooth muscle motility disorder, and it's defined by two simultaneous and really crucial defects in the esophagus.
Okay, two things happening once.
Yes. First, the lower esophageal sphincter, or LES, that's the muscular ring between the esophagus and the stomach, it fails to relax when you swallow. It just stays clenched shut.
And the second thing?
The second thing is a marked and often complete absence of coordinated movement, what we call peristalsis, in the main body of the esophagus.
So the door to the stomach stays shut, and the muscles that are supposed to push the food down have, forgotten how to work together.
Exactly. That combination, it's catastrophic for daily living. The result is a functional obstruction right there at the gastroesophageal junction.
A functional one, not a physical one.
Precisely. Now, the sources are specific that in less than half of patients, the LES is also hypertensive, meaning it has an excessively high resting pressure. But really, whether it's high pressure or just a failure to relax, the result is the same. The esophagus can't empty.
Before we get into the weeds on this, let's just ground ourselves in how rare this actually is. This is not a common complaint.
Oh, not at all. It's extremely rare. We're talking about a very niche but profoundly disruptive disease. The annual incidence is roughly 1 per 100,000 people.
Wow.
And the prevalence, so the total number of cases at any given time is only about 10 per 100,000. Most gastroenterologists might only see a handful of cases in their entire career.
Which makes the research we're about to talk about even more impressive. So you said the core issue is this neurological communication failure.
Yeah.
Where does that breakdown actually happen?
It happens in the nerve architecture that's embedded within the esophageal wall itself. It's called the myenteric plexus. The central defect is the degeneration and loss of specific nerve cells, ganglion cells, in that plexus, especially down near the LES, and also the degeneration of the vagus nerve fibers that control that whole area.
And this is where the story gets really interesting.
It really is, because it's not random damage. It's a very targeted loss of the exact cells responsible for telling the LES to open.
Okay, so let's unpack that precise mechanism. Before the breakdown, how is the esophagus supposed to work? I mean, it's not just a passive chute, it's an incredibly coordinated instrument.
Absolutely. It's performing two vital coordinated tasks. First, bolus transport, getting food to the stomach. And second, just as important, the LES has to prevent the back reflux of harsh stomach acid.
So it's a one-way valve, essentially.
A very sophisticated one. To achieve this, you need perfectly coordinated peristaltic contractions in the esophagus, a wave of muscle squeezing paired with absolutely precise timing in the relaxation of that LES.
A tightrope walk.
Yeah.
You need the push from above and the release from below to happen at the exact same time.
Precisely. And this is all managed by parasympathetic pathways that use two types of neurotransmitters.
Okay.
You have the excitatory pathways. They use neurotransmitters like substance P and acetylcholine. These tell the muscle to contract to maintain tone. They're the close the door signals.
And then I assume they were the ones that say open up.
Yes, and these are the crucial ones. The inhibitory pathways. They use inhibitory neurotransmitters, mainly vasoactive intestinal peptide, or VIP, and nitric oxide. Your sources all emphasize that nitric oxide is the most important inhibitory neurotransmitter here.
So nitric oxide is the key that unlocks the door.
That's the one. When you swallow, these inhibitory pathways should fire, releasing nitric oxide, causing the LES to instantly relax and let the food through.
And this is where achalasia happens. The control system is like a balanced scale, but the weight on the relaxed side is just gone.
That is the core defect. The sources are unanimous on this. In achalasia, there is a targeted, often complete loss of those non-cholinergic, non-adrenergic inhibitory ganglion cells. The nerve cells that make and release nitric oxide are gone.
But, and this is the incredible part, the nerve cells that are screaming, close the door, maintain tone, the excitatory ones, they're totally fine.
That's the key point. This lack of inhibitory input, coupled with the totally normal or maybe even overactive excitatory input, creates this profound and persistent imbalance. The LES is functionally non-relaxed, it's often hypertensive, and it just refuses to open for business.
And that initial failure then kicks off this terrible physiological chain reaction, the vicious cycle of achalasia.
Right. The gradual nerve degeneration leads to that functional obstruction. And the esophagus, it's an organ built for transport, not for storage.
So it starts to back up.
It backs up, pressure builds, and the esophagus above the LES begins to swell and massively dilate. This is a condition called megaesophagus.
And that dilation is more than just swelling, isn't it? It actually damages the muscle structure itself.
It does. The constant stasis and distension eventually lead to an irreversible loss of organized muscle activity, a state they call irreversible aperistalsis.
So the muscle tissue becomes permanently floppy and disorganized.
That's right. The sources are very clear. Once the esophagus is significantly dilated into peristaltic, that structural damage is permanent and the symptoms just get worse and worse.
So the progression is targeted nerve death, which leads to functional obstruction, which leads to muscle dilation and permanent dysfunction.
Exactly.
But what's the initial trigger? I mean, why are these specific inhibitory neurons being destroyed?
That is the central unsolved mystery.
Sure.
While the exact reason is still unclear, the research you sent over heavily favors three main interconnected theories: an autoimmune phenomenon, a viral infection that might act as a trigger, and a genetic predisposition. And we are absolutely going to dive into that autoimmune and genetic link because the evidence is just growing every day.
Before we do, we need to pause and make a really vital distinction between primary and secondary achalasia. This is where the diagnostic stakes get really high.
Absolutely. The vast majority of cases in North America are primary idiopathic achalasia, meaning we see the nerve loss, but we don't know the exact trigger.
But there are other causes.
Right. And every clinician has to prioritize ruling out these secondary causes, which are often grouped under the term pseudoachalasia.
Why is missing a secondary cause so critical?
Because the underlying cause of pseudoachalasia is often something much more sinister, like a cancer or an infection, and mistaking it for the idiopathic version can lead to deadly delays in treatment.
So they can look identical on the surface.
Identical. On a barium swallow or an endoscopy, they can look exactly the same, but their causes are worlds apart.
So give us the key secondary causes we need to be aware of based on the material.
The classic infectious example is Chagas disease, caused by the parasite Trypanosoma cruzi. This is a major cause of secondary achalasia outside the U.S., and it works by having the parasite literally destroy the myotomic plexus, perfectly mimicking the autoimmune process.
So if a patient has traveled to endemic areas in, say, Central or South America, that has to be top of mind.
Precisely. But the most urgent differential is malignancy. Cancer. Secondary achalasia has to be aggressively ruled out, particularly when there's esophageal infiltration by a gastric carcinoma.
A stomach cancer that's grown upwards.
Yes. Or other cancers like lymphoma. Other causes can be things like eosinophilic gastroenteritis or certain neurodegenerative disorders. The entire diagnostic process is basically built around proving that you are not dealing with an aggressive cancer that's blocking the pathway.
That's a crucial takeaway. The pathophysiology is fascinating, but if you miss the cancer, the fascination becomes a tragedy. Okay, let's circle back to the why of the primary disorder. This mysterious, highly targeted destruction of these specific nerve cells. All signs are pointing to the immune system attacking the body's own tissue.
They absolutely are. And the research here is moving so fast. Initially, studies looked at, genetic polymorphisms of the nitric oxide synthase isoforms, the enzymes that make nitric oxide.
Which makes sense, since that's the missing chemical.
It's logical. But the research really caught fire when they started finding these strong links to specific human leukocyte antigen, or HLA, classes.
And for anyone who might not have HLA classes top of mind, those are basically the genetic ID tags on your cells, right?
That's a perfect way to think of it.
If your immune system uses HLA markers to tell self from non-self, then finding an HLA link immediately screams this is an autoimmune disease.
Exactly. And one large European study strongly supports that idea, concluding that achalasia is fundamentally an autoimmune disorder where autoantibodies appear to interact with DNA. This puts achalasia right in the company of other autoimmune conditions like type 1 diabetes and lupus.
And the sources didn't just stop at a general HLA link. They got incredibly specific. What did they find?
They found what is currently considered the most potent known genetic risk factor. It's an 8-residue insertion, a tiny piece of DNA at positions 227 to 234 in the cytoplasmic tail of the HLA-DQ1 gene.
Wow.
This isn't some general susceptibility gene. This is like finding the specific molecular fingerprint of the disease.
An 8-residue insertion. That's just 8 pieces of the genetic code, which essentially flags the nerve cells for attack by the immune system. That specificity is mind-blowing.
It is. It means if you have this specific modification to your immune system's ID tag, your body is much more likely to mount this destructive response against your own inhibitory neurons. And on top of that, they found 2 independent risk factors. 2 other amino acid substitutions and related HLA markers, HLA-DQ1 and HLA-DQ1.
So we have multiple tiny genetic variations that predispose a person to this specific targeted neural destruction. But genetics rarely act alone, right? There's usually an environmental trigger.
Almost always. And that brings us to this fascinating geospatial puzzle.
The north-south gradient.
Yes, this geographical insight is truly strange. When investigators looked at different populations, they found that this specific HLA insertion was significantly more common in Southern Europeans compared to Northern Europeans.
Which suggests something is at play beyond just shared ancestry. Are we talking about an environmental factor that's more common in the South that interacts with this genetic vulnerability?
That is the leading hypothesis. It turns achalasia into an epidemiological detective story.
It really does.
The gradient strongly suggests there's some regional environmental cofactor, maybe a specific virus, a common pathogen, maybe even something in the diet that only triggers the autoimmune cascade in people who have that HLA-DQ1 insertion. If you don't have the genetic flag, the trigger does nothing. If you do, the inhibitory neurons are targeted.
That makes the autoimmune link incredibly compelling. And beyond the genetics, the epidemiology also threw up some surprising demographic shifts and co-associations that are hard to connect at first glance.
Indeed. While achalasia typically affects people between 30 and 60, recent U.S. studies show a marked increase in hospitalizations and costs. The disease burden seems to be growing.
Is the patient profile staying the same?
No, and that's the surprise. The analysis showed a disproportionate increase in patients under 65 and in racial minorities. We really need to understand why that shift is happening. Is it exposure, better diagnosis, or are the triggers changing?
And then there are these really specific co-associations. The one with spinal cord injury really jumped out at me.
It reinforces that neurological origin. The sources note a higher incidence in people who've had a spinal cord injury, specifically damage to the cervical and thoracic vertebrae.
So the neck and upper back.
Right. And given that the vagus nerve, which helps control the esophagus, travels right through that area, a trauma there could disrupt those central nervous system inputs, leading to these motility issues.
Then you have the behavioral links, which are a bit less intuitive.
Yes. For instance, altered esophageal motility, sometimes severe enough to look a lot like achalasia, has been observed in individuals with anorexia nervosa.
Why would that be?
It's debated. It could be chronic malnutrition affecting nerve health or other central nervous system changes, but the link is there.
And finally, a really clear procedural risk factor, endoscopic sclerotherapy for varices.
This is a direct physical insult to the esophageal wall. Achalasia has been reported after this procedure, and the risk goes up with the more sessions a patient has. It suggests that a localized targeted injury to the esophagus can, in some cases, trigger this whole functional failure.
So we have this specific neural defect, probably driven by an autoimmune attack, influenced by genetic susceptibility, and then potentially triggered by a whole range of environmental, behavioral, or physical factors. That is an incredible level of detail for such a rare disorder.
It is.
Let's shift now to the patient experience, what actually brings them to the clinic, and the devastating microscopic damage that's happening under the surface.
When a patient comes in, their symptoms are the starting point, even though we know they can be unreliable for a definitive diagnosis on their own.
The primary complaints are almost universally dysphagia, so difficulty swallowing and regurgitation. The research confirms that 70 to 97% of patients have dysphagia to both solids and liquids when they first present.
And what's often overlooked, especially early on, is how subtle it can be. Many patients first report only struggling with solids. They find that liquids go down fine.
But then it gets worse.
It does. As the disease progresses, the dysphagia includes liquids as well. It's also important to note that those two symptoms, dysphagia and regurgitation, are the ones that respond best to successful treatment.
More than half of patients will also experience significant chest pain, which can be really confusing and severe.
The chest pain can be so intense, so crushing, that patients often get a full cardiac workup first.
They think they're having a heart attack.
Exactly. And a critical clue is that this pain is rarely helped by improving esophageal emptying. It's not to be related to the spastic, uncoordinated contractions of the esophagus above the blockage, or just the tremendous distension of the organ.
And the experience of that pain seems to vary a lot between patients.
It really does. An Iranian study found chest pain was more common in women, while another study showed it was more common in patients under 40. This just confirms why objective testing is so vital. You can't rely on a consistent pattern of complaints.
As the obstruction gets worse, these secondary progressive symptoms start to show up.
Patients start to suffer rapid weight loss because they just can't get enough calories in. They might develop a nocturnal cough or even aspiration pneumonia, especially if regurgitation happens while they're lying down.
Right.
And because the tight LES traps swallowed air, some less common but really characteristic symptoms include hiccups and specifically difficulty or a total inability to belch.
Looking at the physical toll, especially in severe, long-standing cases, the damage goes beyond just the digestive tract.
In the late stages, yes. The patient may look emaciated, and you start to see these extra esophageal symptoms mainly related to the respiratory system from recurrent aspiration of stagnant food and saliva.
And you highlighted the most severe anatomical finding, the bullfrog neck.
It's a striking and thankfully rare description. It's for the most severe cases of megaesophagus, where the upper part of the esophagus in the neck gets so massively dilated that it physically compresses the trachea.
So it actually starts to block their airway.
It does, leading to stridor, that harsh, high-pitched breathing sound. It really emphasizes that this isn't just a swallowing problem. In its most advanced form, it becomes a mechanical threat to breathing.
To bring some objectivity to all of these subjective symptoms, clinicians lean heavily on a standardized tool.
That's the Eckert Symptom Score. It's fundamental for standardizing evaluation, staging the disease, and most importantly, measuring if a treatment is working. It's simple but powerful. It scores the 4 most common symptoms: weight loss, chest pain, dysphagia, and regurgitation on a 0 to 3 scale.
For a maximum score of 12.
Right. And those scores translate directly into clinical stages. A score of 0 to 1 is stage 0, or remission. 2 to 3 is stage 1. 4 to 6 is stage 2, and anything over 6 is stage 3, which means the treatment has failed.
So the goal of any treatment is to get that score back down to a 0 or a 1.
That's the definition of success.
Let's shift now to the microscopic view, the hard evidence of this neurological destruction. What do you see when you look at the tissue?
The histopathology confirms everything we've talked about. You see a significant reduction, often a complete absence, of the myoteric ganglion cells. But the story isn't just one of atrophy, it's one of profound active inflammation.
And that inflammation is the smoking gun, that this is an active, hostile process. What kind of cells are you seeing?
It's a complex infiltration. You see lymphocytes, plasma cells, mast cells all around the nerves. But what is truly striking and noted in all your sources is the presence of activated eosinophils in all of the advanced cases they looked at.
Eosinophils. That points strongly back to an immune or allergic type response being central to this. What are they actually doing to the tissue?
They are the agents of destruction. Activated eosinophils damage tissues by releasing these highly cytotoxic granule proteins directly onto the nerve tissue.
So they're like little chemical weapons.
They are. The sources name them. Eosinophil, a major basic protein, eosinophilic cationic protein, and eosinophil-derived neurotoxin. These are the biochemical agents actively targeting and destroying the surrounding nerve tissue, leading to fibrosis.
So the nerve tissue gets replaced by scar tissue, which leads us back to that fundamental debate.
The crucial debate: is the inflammation a cause or just a consequence? Is it a reaction to food stasis, or is it the primary destructive force?
And one of the studies you sent suggested it's the cause, that inflammation comes first.
Yes. A study comparing early versus advanced achalasia concluded that myenteric inflammation with injury to and eventual loss of the ganglion cells was the initial pathological change.
So it comes before the permanent nerve loss.
It does. And if that hypothesis holds, achalasia is an autoimmune assault on the nervous system that just happens to manifest as a swallowing disorder. And that has massive implications for future drug development.
Before we get there, though, we need to make sure the patient is definitively diagnosed using today's tools.
Right.
So because the symptoms are so unreliable, the diagnostic process has to be this systematic triage.
And the number one objective is the rigorous exclusion of all other causes, especially malignant ones.
Okay, so you start with the classic visual test, the barium esophagogram or barium swallow.
This test provides that iconic visual clue. As the patient swallows the barium, you see this smooth, symmetrical tapering of the lower esophagus, which gives you the characteristic bird's beak appearance.
Right, with the dilated esophagus sitting above it.
Exactly. And during the fluoroscopy, the radiologist is watching for that lack of a proper peristaltic wave. Other signs are an air fluid level or the absence of an air bubble in the stomach because the LES is sealed so tight.
And in very advanced cases, it can look
highly dilated, tortuous, floppy, what they sometimes call a sigmoid-like esophagus because it resembles the sigmoid colon.
And to measure severity and track treatment response, there's a functional version of this test, the timed barium swallow.
Yes, this is for objective quantification. The patient drinks a standard amount of barium, 236 milliliters, and they take x-rays at 1, 2, and 5 minutes. You then measure the height and width of the barium column that's left after 5 minutes.
And a smaller column after treatment means the treatment worked.
It's a clear, objective measure of success.
Okay, so once you have the visual clues, the next step has to be ruling out cancer. So an upper endoscopy or EGD.
EGD is mandatory for all these patients.
Yeah.
Its primary role isn't actually diagnosis. It can be normal in early achalasia, but exclusion. You are looking for any pre-malignant or malignant lesions.
But in advanced cases, the endoscopist will see clear signs.
Oh, yes. They'll see a dilated, tortuous esophagus, often full of retained food and saliva. The junction might have a rosette appearance from the tight muscle, and you can see secondary esophagitis from all the chronic stasis.
This brings us back to that crucial warning, pseudoachalasia. What are the specific red flags an endoscopist has to be watching for?
The clinical picture itself can raise suspicion. An older patient, very short duration of symptoms, but with rapid, significant weight loss, that's a huge red flag.
And during the procedure?
If the scope meets firm, fixed resistance when trying to pass through the junction, that suggests a rigid, possibly cancerous structure, not a tight but flexible muscle sphincter.
And if those flags are there, what's next?
The workup has to be immediate and aggressive. A CT scan of the chest and abdomen, an endoscopic ultrasound to look at the walls and lymph nodes, maybe a transabdominal ultrasound. You have to rule out malignancy.
So barium provides the look, EGD provides the exclusion, but for the definitive diagnosis, we need the gold standard,
which is high-resolution manometry, or HRM. It's the most sensitive test and the absolute gold standard for diagnosing achalasia. It gives you this detailed topographical pressure map of the entire esophagus.
So you can see exactly what the muscles are doing or not doing.
Precisely. It confirms the core mechanism, incomplete LES relaxation when you swallow. And it confirms the lack of effective peristalsis in the esophageal body.
And the real power of HRM is that it doesn't just diagnose achalasia. It classifies it using the Chicago criteria, version 3.0. Why is that classification so important?
It's vital because the 3 different types have very different prognoses. They tell you how well a patient is likely to respond to different treatments.
Okay, so they all share that incomplete LES relaxation, but it's how the muscle above the sphincter behaves that determines the type.
Exactly.
So let's break them down, starting with the classic failure type 1.
Type 1 achalasia is defined by complete aperistalsis. The muscles are basically paralyzed, and there's no esophageal pressurization. This is the classic simple motor failure. The system is paralyzed, the door is locked shut.
Okay, what about type 2? This is the interesting one because it has the best treatment response.
Right. Type 2 also has aperistalsis, but it's defined by panesophageal pressurization. So the whole esophagus pressurizes at once in 20% or more of swallows.
Like a compressed tube.
Exactly. It suggests the muscle isn't totally dead, it's still trying to contract against that closed LES. And because it still has that ability to generate pressure, this type has the best prognosis and the best response to treatment.
It's like there's still some life left in the muscle, even if it's uncoordinated. And then we have type 3, the chaotic, hyperactive one.
Type 3 is often called spastic achalasia. It's characterized by these premature spastic contractions. It's identified when the distal contractility integral, or DCI, is over 450.
So what that metric is really telling us is that the muscle isn't just dysfunctional, it's engaging in these chaotic, violent contractions.
Exactly. Instead of paralysis, you have violent, disorganized spasms. And this aggressive, hyperactive behavior makes type 3 really challenging to treat. It has the least favorable response to traditional therapies.
So type 1 is paralyzed, type 2 is compressed, and type 3 is spasming out of control.
That's a great summary. And the Chicago criteria give you the roadmap for which treatment to choose.
Which means the diagnosis doesn't just give you a name, it gives you a targeted, evidence-based plan for management, which is where we should go next.
Absolutely. The fundamental goal across all management strategies is purely symptomatic relief.
Right, because the nerve damage is irreversible. You can't restore normal function.
You can't. So you're focused entirely on one thing, reducing the outflow resistance from that non-relaxing LES. You have to force that door open permanently.
Let's start with the least invasive options, like pharmacotherapy. But this sounds like a temporary fix at best.
It is. It's rarely, if ever, considered a definitive treatment. It's for patients who need temporary relief or are too high risk for a procedure. The medications are things like nitrates, calcium channel blockers.
Things that relax smooth muscle.
Right. But they have major limitations. They only offer short-term relief, patients develop tolerance quickly, and they have systemic side effects like hypotension and headaches. They just can't provide the sustained relaxation you need.
Okay, so next up is a more localized chemical intervention. Botulinum toxin injection. This sounds like you're trying to chemically paralyze the muscle.
That's a great way to put it. The toxin from Clostridium botulinum is injected right into the LES. It works by blocking the release of acetylcholine, the excitatory, close-the-door neurotransmitter.
So you paralyze the closed signal to force it to relax?
Yes. It's useful for high-risk patients or as a temporary bridge, but the trade-off is clear. It's very short-lived.
How short?
The effect only lasts about 6 to 12 months, so you need multiple expensive treatments. And critically, the injections cause inflammation and fibrosis that can make a later surgery much harder and maybe less successful.
So if surgery is an option, you'd probably avoid Botox.
Many clinicians would, yes.
Okay, so then we move to the definitive non-surgical approach, which involves physical force. Pneumatic dilatation or PD.
Pneumatic dilatation is widely considered the most cost-effective non-surgical therapy. It's a brute force approach. You use an air-filled balloon catheter to forcefully disrupt the circular muscle fibers of the LES.
You literally tear the muscle fibers.
You do. It's typically done with a graded approach, starting with a smaller balloon and moving to larger ones over several sessions.
How well does this work long-term?
It gives symptom improvement in 50 to 93% of patients. The big drawback is recurrence. About 30% of patients have symptoms return within 5 years.
But you can do it again.
You can. And the sources note that if patients get repeat PD on demand when symptoms come back, the long-term remission rates can actually approach those of surgery.
Are there specific people for whom PD is known to fail?
Yes, there are clearly identified failure groups. Success rates are lower in men, especially young men under 40. Also in patients with pre-existing lung complications or those who failed dilatations before.
And what about the risks of the procedure itself?
The most severe risk is esophageal perforation, which is a surgical emergency. But it's rare. And interestingly, PD is often the first choice if a patient's symptoms return after a previous surgery has failed.
Okay, so now let's get to the definitive surgical options, starting with the long-standing gold standard, laparoscopic Heller myotomy, or LHM.
LHM is the procedure of choice for many. It's a precise, targeted surgical cut. Using a laparoscopic approach, the surgeon cuts only the circular muscle fibers at the LES and a little bit of the adjacent stomach.
So you're physically disabling the muscle's ability to contract.
Exactly. It achieves sustained relaxation.
But as you said earlier, if you disable the muscle that keeps the door closed, you immediately create a huge risk of reflux.
That's the critical trade-off. LHM almost always causes uncontrolled gastroesophageal reflux. So the procedure is almost always paired with a partial fundoplication.
An anti-reflux wrap.
Yes. The anterior door fundoplication is the most common. A piece of the stomach is wrapped partially around the esophagus.
And the sources are really clear that it must be partial. A complete wrap, like a Nissen, is a bad idea here. Why?
It's crucial. If you do a complete tight wrap, you essentially create a new artificial blockage. You replace the achalasia with severe postoperative dysphagia. The wrap has to be partial to prevent reflux while still letting food pass through.
And how successful is LHM as a long-term fix?
The success rates are excellent, between 76 and 100% at about 3 years. But like all treatments, the success rates do decline after 5 years as the underlying disease progresses.
Finally, we have the newer, minimally invasive alternative, POM.
Peroral endoscopic myotomy. It's a highly effective technique done at specialized centers. Instead of external surgery, the muscle cut, the myotomy, is done entirely with an endoscope from inside the esophageal wall.
So it's the same functional cut as an LHM, just without the incisions.
That's right.
What's the major trade-off when you compare PO to LHM?
The key trade-off is that high risk of reflux. POM doesn't include an anti-reflux procedure, so patients often need to be on long-term acid-suppressing medication.
But it has a specific advantage for one type of achalasia.
It does. It allows for a much longer myotomy, which is a huge benefit for treating Chicago type 3. Because type 3 has all that spastic activity high up in the esophagus, POM is considered the initial treatment of choice for that specific group.
And if all of these approaches fail, what's the absolute last resort?
That would be esophagectomy, the surgical removal of the diseased esophagus. A massive operation reserved for the most severe failed cases.
So summarizing the prognosis, we have two excellent definitive treatments, but with different risk profiles.
Precisely. Pneumatic delabitation and myotomy both give excellent symptom relief. The difference is the risk. PD has a low risk of perforation, but high relapse rates. LHM or POM involves a bigger initial procedure, but offers a more definitive long-term solution.
Okay, let's try to synthesize everything we've talked about.
So if we boil down the core knowledge points from your sources, achalasia is this rare, complex disease defined not by a mechanical block, but by a profound neural inhibitory failure.
The loss of those nitric oxide neurons.
Exactly. And we now know this failure is highly correlated with specific genetic markers, especially that HLA-DQ1.
The diagnosis hinges on the gold standard, high-resolution manometry, which uses the Chicago criteria to classify it into one of 3 types, which then guides treatment.
And that management focuses entirely on mechanically disrupting that closed LES door, either with a forceful balloon dilatation or a surgical or endoscopic muscle cut.
And we must always circle back to that critical diagnostic context.
Yeah.
The constant need to rule out pseudoachalasia.
Always remember malignancy, especially in older patients with rapid weight loss or a scope that won't pass.
And don't forget the differential diagnosis list: diffuse esophageal spasm, scleroderma, strictures, GERD, all things that can mimic these symptoms.
And this is where it all connects back to the beginning, the autoimmune etiology. The most striking finding in the pathology was the presence of those lymphocytes and activated eosinophils. It confirms this is an active, ongoing inflammatory process.
The conclusion that myenteric inflammation with injury is the initial change suggests we might be treating the wrong thing. We're doing all these mechanical fixes, cutting muscles, forcing balloons that just deal with the consequence of the destroyed nerve tissue.
And that leads us to our final provocative thought for you to mull over. If the initial event in achalasia is an autoimmune or inflammatory assault on these nerves, what might future treatments look like if they move beyond just mechanical fixes?
You mean, could we intervene earlier?
Could we see the development of novel therapies, maybe immune modulators or targeted biologics, that stop the eosinophils and lymphocytes from destroying the nerve tissue in the first place? Could we arrest the disease before the functional failure even begins?
A true medical remission versus just forcing the door open. That's a massive shift in how you think about treating this.
A total paradigm shift waiting to happen.
Until then, keep digging.
Exactly.
That's all for this deep dive into achalasia. Thank you for sharing your sources with us, and we look forward to the next complex topic you send our way.